Okay, let's look at Chapter 9 for HIMT 2200, Performance Improvement. In Chapter 9, we start focusing more on the patients themselves. I mean, we've been talking about processes and teams and committees and things like that, but now we're starting to focus on the individual, the patient. So this chapter is basically kind of two parts. The first part of it is looking at what we call the core processes, which are involved in the care, treatment, and services for the patient. And then the second part of the chapter is basically the steps that get us to where we need to go, that being successful care of the patient. And then the last part of the chapter is what they call ongoing development. So, all right. So let's focus for just a minute on the first part of the chapter, and I want you to look at the term core processes. And there's just four, and basically it's assessing, planning, providing, and coordinating. So let's kind of break those down for just a minute. When you look over at page 155, there's a good little illustration there that kind of shows how it's a cyclical process. What we're doing, we're assessing the patient, and that can come from different avenues, the intervention, the looking at what happens, reassessing that patient, and then they may need to continue their care. Sometimes, like I mentioned in the book, it's a quick emergency room visit, or and they're done. They're okay. Maybe they broke their finger, or not their finger. Maybe they broke their arm. They get it casted. They heal up, they're all good. But then sometimes it can be an ongoing chronic issue that keeps having to come back for additional treatment. So that's what they're demonstrating there on page 155. Again, sometimes it's reassessed, all good, discharge, go home. However, it could continue to keep cycling through the processes over and over and over again. Okay, so let's look at core process number one, and there's that image of that is in your book. Okay, all right. Let me come back here. There we go. All right. So when we talk about core process number one, of course, this was assessing the patient's needs. And there were four key components of what we need to do when we're looking at assessing the patient's needs. But look what they say. The cornerstone of good patient care is the initial assessment, which determines the patient's appropriateness for admission to the facility and the level of care to be rendered. So there's several things that we look at here. We look at, their physical status, their psychological status, their social assessment. That's why we're always asked various questions about, I know every time I go to the physician, I'm asked, do I have any inclination to do harm to myself? So they're evaluating my psychological status. They look at nutrition, hydration status, functional status, how well an individual performs activities on a daily basis. Are we establishing whether this patient really needs to be living alone, or do they need some sort of extra care, or is it time to make that move into some sort of assisted living facility? They're also looking at social, spiritual, cultural variables that influence the patient and family members' perception of their lives. So, we kind of, these things can really affect our day-to-day living. So again, we're assessing all of these things, and we can't discount, spiritual. We can't discount cultural variables. I mean, these things are important in the overall care of that patient, so we don't want to discount those. We look for signs of victim abuse or neglect or alcoholism, and there's certain things that have to be reported by law to local authorities, state authorities, etc. So those are things that are being assessed for the patient, all part of core process number 1. Now, we go on over and begin talking about core process number 2, and this is the planning care, planning the treatment, and planning the services. So when we look at this definition, it says if the appropriate need for admission has been determined, the establishment for an interactive written care plan that is specific, individualized, and based on thorough assessment of the patient's physical, emotional, social, cognitive, and cultural needs is the next step in the care process. So we've got to determine, what are we going to do for this patient? So that's the planning of the care, treatment, and services. And sometimes it'll involve, groups of people that are looking at what is the best course of treatment and care, and what services can we provide to that patient. So far we've talked about assessing, then planning. Okay, again, we're talking about the 4 core processes, and this is all about patient care. Okay, so assessing and planning. Now let's talk about providing that care. Pretty basic, it's pretty self-explanatory. It says in many healthcare settings, the care pathway has become a model for the documented outlines of patients' progression of treatment. So it says a multidisciplinary team. When we say multidisciplinary, this can be a variety of people that are offering their input, not just physicians. It can be nurses, physical therapists, occupational therapists, oncology, and it can be a lot of different people brought together. But they develop this care pathway. In other words, basically, okay, if this is the situation, this is where we need, this is our established protocol of what we need to do for this patient. Okay. All right. I was just looking at some information here. It says the goals of a care pathway are broad in scope and set the overall direction of the care. The pathway defines the specific treatment and its timing and frequency. It says many healthcare facilities use a system of care based on established national clinical standards for treatment interventions, which have been extensively researched. So this, this care pathway that has been decided upon for this patient is not just guessing. It's based on, what, looking at national results, and a lot of information that's helping them determine a plan for that patient. Okay, if we look over on page 158, we see there an extensive care pathway. This is a care pathway specifically for adults with MRSA, and it's just basically how are we going to treat this patient? What should we be assessing as we're going? What should we be monitoring? And it's just a great checklist to make sure that things don't get overlooked. Okay, so having it in writing, having a checklist, having a plan written out, not just discussed, is helpful in the what we're now about to talk about. And did I miss one? Nope. The actual coordinating care. So that leads me to process number 4. It says this is the coordinating care, treatment, and services. It says the expected interval or eventual, outcome of the flow of care is an improvement in the patient's condition that allows discharge to the patient's home for a different care setting. So we've assessed the patient, we've decided on a plan, we've provided that care and treatment based on that pathway that we've looked at, that care pathway, and now we're looking at the outcomes of that. So when you look at and it's a little bit misleading, but core process number 4 is coordinating care, treatment, and services. And again, if you think about the word outcome, that will help you remember what this core process is all about. So again, let's look at that definition there. It says the expected eventual outcome of this flow of care is the improvement in the patient's coordination condition that allows discharge to the patient's home or possibly a different care setting. So again, this is hopefully where things have improved. They're now going to be able to go home or maybe go back to the assisted living, hopefully. So all right, let's look at the check your understanding here. The core care process that determines the patient's appropriateness for admission to the facility and the level of care and service to be rendered is called the assessing the patient's need. That's that core process. And again, please make sure you review and can identify what these 4 core processes are: assessing, planning, providing, and coordinating. But this one where they're looking, should we admit this patient? This is the assessing the patient's needs. Number 2, Betsy is admitted to the hospital through the emergency department with congestive heart failure. After her initial assessment was completed, it was determined that Betsy met the criteria for inpatient admission to treat her condition. Her nurse is writing her care plan that is based on the established protocol. Based on this scenario, what is the nurse using to develop Betsy's care plan? And this is a care pathway. So again, we have these pathways already in place that when a patient comes into a facility, this is kind of our checklist of what we should do for that patient once they're diagnosed with a certain illness, okay? Care pathway. Now, the next little section is where we get into the optimizing the patient's care, and these are various steps to success. And what we're looking at here, if we look on the bottom of page 159, it says the treatment and care of the patient in the healthcare system can be measured in many ways. Different measures can be used to identify problems, demonstrate compliance with regulations, or reflect improvement in patient's care process. However, some problems are more easily measured than others. For example, it is easier to measure the number of patients who receive a preoperative dose of antibiotics to prevent post-operative wound infection than it is to measure that particular intervention's effect on the occurrence of infection in a specific individual. So what we're about to get into here are basically what we call improvement processes that we can adhere to. So let's look at step 1. Step 1 is about conducting patient care outcome reviews. So what we want to do here is always evaluate, look retrospectively at, what happened during this patient's care. Did we achieve the hope, the anticipated outcome, or the optimal outcome? If not, why? What we could have done differently. So we're constantly always looking at this, and certain organizations, whether it be accrediting organizations, Center for Medicare and Medicaid, they're always requiring that we look at these things. And they talk in step 1 there about what's called core quality measures. And there's certain core quality measures that inpatient facilities have to constantly look at and measure of how they're doing with patient outcomes. And they're mentioned there accountable care organizations, patient-centered medical homes, and primary care, cardiology, gastroenterology, HIV and hepatitis C, medical oncology, orthopedics, obstetrics and gynecology, and pediatrics. So again, the collaborative has this collaborative organization, this core quality measures collaborative effort has developed metrics for the following sets of core measures based on claims data, and those are mentioned there. What have we gotten? 8 of those. So make sure you look at those. Number 2 is about conduct evaluations of the organization's use of seclusion, restraints, and protective devices. You have to be very, very careful about what we're doing here because you cannot deny the patient basic needs, food and water. You cannot deny them shelter. You cannot deny them essential safe clothing. You cannot use corporal punishment, fear eliciting techniques, mechanical restraint and seclusion, any procedure that allows a patient to implement behavior management or treatment techniques on other patients. Now, there's certain things that can be done for the protection of that patient. You know, certain restraints used during surgical events, certain restraints used during dental events to make sure that we don't do harm to that patient. So there's certain things that are allowed, but this is where you have to be very careful about things, and there should be protocols in place. There should be extensive training in place to ensure that none of these are violated with regard to seclusion, restraints, and protective devices. Now, another step, and again, we're talking about steps to success in optimizing that patient care, but another one is centered around laboratory services and the use of blood products. And look at that first paragraph there on the bottom of page 161. It says laboratory services are regulated by established protocols from the for Disease Control and Prevention. We know it as the CDC, and the Clinical Laboratory Improvement Amendments, the federal regulations outlining the quality assurance activities required of laboratories that provide clinical services. Also, equipment calibration and other parameters for laboratory values must be monitored on a daily basis. So this little section is discussing you know, the criticalness of making sure that laboratory services are done correctly, the use of blood products is done correctly, you know, how we label vials, how we handle those samples, how we conduct those tests, how we perform transfusions, because we certainly don't want to have a patient with what we call a transfusion reaction, where they've been given the wrong kind of blood. I mean, it could be a minor reaction, but it could be a whole lot worse than that. So there's certain protocols that have to be done to ensure that you know, there's that two patient identifiers must be used. You know, asking them questions, making sure that you're ensuring that this is indeed the patient you anticipate you're about to, you know, give a medication to. You know, double checking, you know, blood components. These things are incredibly important to make sure that we don't end up with some sort of sentinel event that could have devastating effects. Conduct evaluations of the organization's medication systems. There'll be more about this in another chapter, but basically this is, you know, a huge part of a facility, inpatient facility. There are tons of different medications being administered throughout a hospital, and there has to be very, very strict protocols of how this should be done, but we'll cover that more extensively in chapter 12. Step 5, conduct policy, procedure, and documentation reviews. We always need to be looking at our protocols, our care pathways, our what we call SOP, standard operating procedures, and we need to make sure these policies are reviewed fairly often and updated as necessary. So, Another step would be evaluate the organization's standards of care and care pathways. It says for a healthcare organization to define optimal care, it must first establish a set of clinical decisions and actions taken by clinicians and other representatives of healthcare organizations in accordance with state and federal laws, regulations, and guidelines. These are known as standards of care and care policies. It says some healthcare organizations have moved from a policy and procedure format to what we call a clinical practice standards model. So these standards of care are necessary to make sure we keep them updated and current. Check your understanding. It says Jim was admitted for hip replacement surgery, and during the procedure, he was administered a blood product. Postoperatively, Jim developed a rash and fever. The presence of these symptoms should be investigated by the hospital. This could be a transfusion reaction. So, number 2. An established set of clinical decisions and actions taken by clinicians and other representatives of healthcare organizations in accordance with state and federal laws, regulations, guidelines is also called a standard of care. Defend this practice and why it is critical to quality care and patient safety. I think it's kind of self-explanatory in that we have got to, let's see where I was going, get over here. And if you look in the back of your book, they give you a little bit more information about this. It says for healthcare organizations to define optimal care, it must first establish a set of clinical decisions and actions taken by clinicians and other representatives. It says these standards of care are based on evidence-based practice and research to provide the optimal results for the patient safety and quality of care. So, you know, we can't ignore what we call evidence-based medicine, things that work for those patients, and we need to make sure that we follow what's been laid out for us. All right, let's look at ongoing developments. Let's look at NPSG. This is the National, the National Patient Safety Goals. I get all my acronyms mixed up for a minute. But basically, the Joint Commission established these, and if you look over at page 164, this is what the Joint Commission tells us should be part of the National Patient Safety Goals by identifying the patient correctly, improving communication, use of medicine, use of alarms, how to prevent infections, which is a big thing for a hospital, because if that infection is not present on admission and the patient develops that infection, you know, the hospital is likely to risk losing reimbursement on that patient, because Medicare, if an infection is not present on admission, will not pay for the care of that patient in most cases if the patient develops that infection in the hospital, well, after they've been admitted to the hospital. Identifying patient safety risk. This is all part of the National Patient Safety Goals. Prevent mistakes in surgery, prevent patients from falling, prevent bed sores, okay? Okay. Oh, they also give a little example of a protocol for surgery. And if you've experienced surgery in the last few years, you know exactly what I'm talking about, but conduct a procedure verification process. Typically, the physician, the surgeon will come in and speak with the patient, discuss what they're going to do, make sure they all are on the same page, marking the procedure site. You know, you've heard those horror stories of the the wrong limb being operated on, um, um, or amputated, or just horrible situations, but also perform a time out before the procedure. In other words, you know, meeting with the surgical team to have a moment of, okay, what are we about to do, having a discussion, making sure everybody's on the same page before we start cutting. National standardization of care processes. In this little section, it says the evaluation of patient care across all settings is extremely difficult, because think about all the different moving parts of a facility, and having everybody working in the same direction can be quite challenging. So these national standardization of care processes go on to say here, the expectation is that healthcare will be individualized, because what works well for one patient may not work well for another. Some healthcare researchers, particularly those working in federal government, have spent millions of dollars in years to research and develop what we call clinical guidelines. So let's look at the definition of clinical guidelines. Make sure you look at this. It says these are descriptions of medical interventions for specific diagnosis in which treatment regimens and the patient's progress are evaluated on the basis of nationally accepted standards for care of each diagnosis. These guidelines attempt to standardize the care of a single condition across the entire country. However, many clinical practitioners find that the guidelines difficult to implement and even contraindicated in some cases because of comorbid conditions or social ramifications in patient clinical presentation. So, you've got these clinical guidelines, and they're great for guidance purposes, but they don't always apply to the particular situation. I mentioned evidence-based medicine a while ago. Evidence-based medicine attempts to identify the care processes and interventions that achieve the best outcome in different types of medical practices. Researchers perform large population-based studies to come up with these, what we call evidence-based medicine. In other words, here's what has worked in certain situations. Okay. Right. They mentioned there what we call patient care initiatives. An organization published this set of what we call patient principles of patient-centered care. There were 8 items there: respect for patients' values, preferences, and expressed needs, coordination and integration of care, information, communication, and education, physical comfort. Emotional support and alleviation of fear and anxiety. We shouldn't discount that. Involvement of family and friends. Family and friends can be very therapeutic for a patient, and involving them and empowering them to help with the care of that patient can be very helpful. Continuity and transition, and then access to care. So these are all principles that they've established, the Picker principles of patient-centered care. Patient-centered care, they have it defined down at the bottom. Said the patient care process cycle, with the emphasis on respect of patients' values, preferences, and expressed needs, and the emphasis on the provider's cultural competence, information, and education regarding the patient's condition under treatment and the modalities of treatment being utilized. Access to care at levels appropriate to the patient's current progress, involvement in a family to the level okay, involvement of the family to the level that the patient desires, pain management, continuity and coordination of care as the patient progresses from one level of care to another, from one type of provider to another. That was a long sentence there, but basically they're summarizing what's in that figure 9.5 above that point. And again, we shouldn't discount the patient's values, their preferences, their expressed needs. We have to consider those things. So some of these things, we might tend to discount because a physician thinks they know better, but we have to take those things in consideration when we're caring for the patient. I mean, when you start talking about doing surgery on a patient, that generates a lot of anxiety, a lot of concern, and a physician, the clinical team shouldn't discount that, and they have to do what they can to give that patient reassurance and listen to that patient. Okay, over on page 166, we begin talking about, the innovations of, get to where I need to be. We start talking about telehealth. We've never seen so much telehealth going on as we have currently in this this pandemic that we're in. The use of telehealth has exploded, but according to our textbook, telehealth was used for patients who couldn't travel because of physical limitations, or maybe rural physicians would use it to communicate with some of the bigger city physicians. So before this pandemic, there was telehealth, not as widespread as it is now. Now in this pandemic that we're in, a lot of people are using telehealth because they don't want to go in these facilities and be potentially exposed to things. But telehealth has a lot of benefits to it. Now, the next and almost last thing I need to talk about is what's called the minimum data for long-term care facilities. There are a lot of different data sets that we track. This specific one is the minimum data set for long-term care, and basically what it generates based on a lot of different data elements is information about the patients in those facilities and how they're doing from day to day. So we're constantly assessing this information, tracking this information, because we ultimately want to generate what we call a facility quality indicator profile. And what this is basically a report card of how that facility is doing, because there's certain things that we track for long-term care facilities that we wouldn't track in an emergency room setting. That's a whole nother data set. But if you look at some of the things that are tracked with regard to long-term care facilities, vision function, communication skills, delirium, falls, oral and nutritional needs, oral and dental status. I mean, these are things that typically it's going to be elderly individuals that we need to be tracking. Pressure ulcers, that's big in a long-term care facility. But so basically, they're required to track this information, and then ultimately that information is used to generate what we call a facility quality indicator profile. And if you kind of thumb through this, I'm not going to go through this in detail, but if you look at it, they're generating this for the Shady Acres Nursing and Rehab Center, but also they compare it to state averages and national averages. Okay, so not that a patient is falling is a good thing, but if we're below the state average and the national average, then we know that there's falls can happen, but it gives us an understanding of, are we way out of the norm? If you look over at page 169, there was one there that says the percentage is the one that lower percentages are better. Percentage of short stay residents who are rehospitalized after a nursing home admission. So Shady Acres is at 13.9%. The national average is what, 22.4. So we're doing well there. We're only at 13.9%. So the lower the percentage, the better there. Okay. We're doing, if we look at the percentage of short stay residents who improved in their ability to move around, we're on the lower side of the state and national average. So that might be a red flag for us. Okay. All right. So again, this is the facility quality indicator profile that the facilities must, if they accept Medicare and Medicaid particularly, they must track this information. Okay. All right, I am going to go ahead and look at the review questions. Some of these we can very clearly answer. That second one there is kind of one of those that could vary from student to student, but I am going to go ahead and look at 1, 3, 4, and 5. Number 1, it says list the 4 core processes, and running back up here in the presentation, there they were: assessing, planning, providing, and coordinating. So assessing the patient's needs, planning care, treatment, and services, providing that care, treatment, and services, and coordinating that care, treatment, and services. And remember, with the coordinating, that was more about outcomes. Okay. Number 3, it says the descriptions of medical interventions for specific diagnosis in which treatment regimens and the patient's progress are evaluated based on nationally accepted standards for care for each diagnosis is called the clinical guidelines. Clinical guidelines. Number 4, a graphics tool used to communicate established standards of patient care for specific diagnosis is called the clinical cares pathway. So, the key word there was that it was a graphics tool, and there was one that was displayed in your textbook, a visual, kind of almost like a flow chart of what we should do, what we should follow up on, what we should monitor, what we should assess. Number 5, assess how tailoring care around patient preferences is changing the way healthcare is being delivered and how this impacts the patient care outcomes. And, patient preferences can be, like we've talked about, cultural, spiritual, things like that. But, the lighting in the room, are they cold? Are they hot? What are their preferences? What can we do to make them comfortable? That's a very psychological thing for patients, and so the more we can look at those needs, hopefully it can help improve the patient themselves. Okay, we want them calm. We don't want them agitated and anxious and concerned, and we want to do that. We want to call them by the name they want to be called. So those are just things that we can do to look at the patient's preferences. Okay. All right, so that is chapter 9. That's, again, all about, the patient care, looking more at the patients and what we can do for them to ensure that they get the best quality care and treatment. Okay, so that was chapter 9. Thank you so much.